Assalamu alaikum wa rahmatullahi wa barakatuh. A very good evening to all the doctors and the medical fraternities who have assembled online for this wonderful scientific session entitled NNF Neonatal Symposium, organized by NNF UAE chapter in association with Emirates Specialty Hospital and Vitabiotics in KZ. Myself, Tawfiq Ali, Country Business Manager of Vitabiotics in KZ. Along with me, I have the office bearers of NNF, Dr. Monica Kaushal, Dr. Sridhar Kalyan Sundaram, Dr. Rajesh Sharma, Dr. Lilian Maher, the brand manager of KZ, and Fadi Marcos, product manager of KZ. To move ahead with the proceedings, I would like to ask Dr. Sridhar Kalyan Sundaram to come online and give the welcome note. Dr. Sridhar, please.
Thank you, Tawfiq. Welcome everyone. It's very nice to see more than 1,000 registrations, and obviously it's a very important session. Lots of critical care stuff being discussed by Dr. Alok and Dr. Jasim. So should be a great session for everyone. As President of the NNF Emirates, I wish to welcome you all to join us for this evening. And we have been organizing regular sessions, and recently it has been in partnership with Tawfiq and his team, who have done a great job. Thank you, Tawfiq, for that. And Dr. Monica has been behind all this with her hard work, coordinating and arranging great sessions. So it's all kudos to her. Thank you, Monica. So I will hand over to my colleague, Dr. Rajesh Sharma, who is the President-elect of the NNF Emirates, and he is consultant neonatologist at Cornish Hospital, Abu Dhabi. He is also the lead for the Vermont-Oxford Network data collection. We were having a chat about how tough the job is, and especially the storage. So he might give you a tip on how to do that as well. So thank you, Rajesh. Please take over and start the proceedings.
Thank you, Sridhar. Thank you, Tawfiq, Monica, and I welcome Aloof and Jasim, along with one of our moderators, Dr. Sharif Mossad. It's my pleasure to introduce him and welcome him as a moderator for this first session. He is an accomplished and experienced pediatrician and neonatologist who's been working in UAE for almost 25 years. He was with MOH and he's also professor of pediatrics at Russell University, Medical University, for last 8 years. He was president of Emirates Medical Association, and he is instructor for NRP. Currently, he is working as a head of the department at Amina Hospital, Ajman. So over to Dr. Sharif. Is he around?
Hello, good evening. Thank you very much, Dr. Rajesh, for this very interesting introduction. First, I want to thank Dr. Monica and Dr. Sridhar for inviting me for this elegant webinar. And they are founder of the National Neonatology Forum. Thanks for Dr. Tawfiq also for organizing of this webinar, and thanks for all. We hope that you enjoy for that nice and update neonatology webinar. My pleasure to introduce Dr. Aloof Sharma. Dr. Aloof Sharma is a consultant neonatologist in Princess Anne Hospital in Southampton in United Kingdom. Dr. Sharma, he's an experienced medical professional with a unique expert in the innovation and education. In addition to his clinical practice, he's practicing about his 20 years in pediatric neonatology. He has led to a wide range of educational programs, including the IMPROVE. IMPROVE, it is an abbreviation of multi-professional neonatal education, which is give free global access to the high-level clinical information and resources. So Dr. Aloof, he has his YouTube channel, and I advise all of you to watch this YouTube channel for Dr. Aloof. He's an updated and very interesting lecture about the neonatology. Dr. Aloof, he will speak today about the very important subject, approach to difficult neonatal airway management. So let's welcome Dr. Aloof, and we are happy to hear from you. Mic for you, Dr. Aloof.
That's really kind. Can everybody hear me?
Yes.
Fantastic.
Yeah.
And is the presentation visible?
Yes.
Yeah.
Yes.
That's really kind. So I'd like to thank Dr. Rajesh, Dr. Monica, and Dr. Kalyan Sundram from the NNF UAE for giving me this opportunity to actually speak to all of you. Extremely grateful, but also would like to thank uh, Dr. Kalyan Sundram and Dr. Kaushal. They're supporting us in our initiative with the Improve Academy. They will be helping us with our module on perinatology and ethics, and I'm extremely grateful. I'd also like to take the opportunity to thank Dr. Sharif for introducing me, and Tawfiq for helping me through the IT. What I'm going to do today is I'm going to give you a little bit of an overview of how you can develop an approach to management of the difficult neonatal airway in your setup. I think the most important aspect of this is there is a wide variation in the availability of technology that's available all over the globe. But the most important thing from our perspective is that there are airway adjuncts that are available, which if used appropriately can really help you in situations where you're having difficulties with either intubation or ventilation of a baby, or even mask ventilation. So as a start, what I will be doing is taking you through the definition of the neonatal difficult airway. I'll be discussing some of the existing frameworks as they are in the UK that we have recently developed with the British Association of Perinatal Medicine. In addition to that, I will talk to you about the human factors approach to how you should approach unexpected difficulty in airway management in a baby. We will then talk about certain situations, and I will then share with you my algorithm. I will be sharing my presentation and the algorithm with all of you through Mr. Tawfiq. So feel free to email him for the presentation. We will then talk about a case, and then at the end, I will summarize of how you can actually develop a difficult airway algorithm for your own local setup, even if you don't have, I would say, the high-tech gadgetry. You know, to be honest with you, you don't need it. But in some situations, obviously, being able to use a video laryngoscope is something that I am extremely passionate about. And both me and Justin, who will be speaking to you after this, have got a special interest in video laryngoscopy in the management of the neonatal airway. I think first and foremost, what I'd like to do is try to define what the difficult neonatal airway is, because there is a huge difference between the neonatal airway and the pediatric airway. I think I can't emphasize enough that when we manage babies and when we have difficulties with intubating and ventilating them, we work in a diverse setup. So we can have difficulties from soon after birth in the delivery suite to having difficulties if you're just doing a routine elective intubation on the neonatal unit. And the key aspect of that process is trying to recognize where you are having difficulty. Now, how do you define the difficult neonatal airway? So it's not enough for us to say that if we had a baby where we could see the glottis but couldn't pass a tube in, that airway is difficult. Because if you look at the spectrum, for the expert who has a lot of experience in intubating that baby, that failure might just be due to secretions. But for the novice learner who's actually intubating that baby for the first time, in his mind, that airway would be difficult. So what we have to do is we have to make this very objective. And the way we've done that is by using a definition which says that if you're having difficulty inflating the chest, either using face mask ventilation, or you're having difficulty with tracheal intubation because you either can't visualize the glottis, or you can visualize the glottis but can't actually pass the ET tube and cannot then effectively ventilate the baby, that for you would be the objective definition for a difficult neonatal airway. The fact is you might actually encounter both of these problems. What is absolutely essential in those circumstances is that you differentiate between the airway that is merely difficult, where you are able to manage the baby, you are able to successfully either ventilate or oxygenate that baby by a means other than a mask or through intubation, versus an airway that's critical. And a critical airway is an airway where you would not be able to back valve mask ventilate the baby, nor would you be able to visualize the glottis, nor would you be able to intubate the baby. Now, that is a very serious condition, because in that situation, the baby will become very severely bradycardic and hypoxemic over time. And time is of the essence, in that if you have repeated failed attempts at trying to intubate that baby, eventually those babies develop glottic edema. And in the wrong hands, babies can die very quickly. For us, a critical neonatal airway in our setup would prompt us to be calling a pediatric anesthetist or an ENT specialist who specialized in pediatric ENT, so that they can actually help us with the fiber optic intubation. Very rarely, and as I'll discuss with the last case with you, sometimes what we have to do is we need to get ENT in order to give us a surgical airway. In my career, 20 years, I've only had to do that once. So it's fairly uncommon. But I think the critical difference is that with a difficult airway, you as an experienced neonatologist or pediatrician will be able to manage that airway either by special intubation techniques, either by airway adjuncts, or by using your team in such a way that you can actually manage the airway until such time as you get expertise to come and help you. That might be an extra pair of hands, another colleague, or it might be a pediatric anesthetist or ENT. But where the airway is critical, structural airway abnormalities, tracheal stenosis, or glottic obstruction, in those situations, it's very unlikely that you, with your skills on your own, will be able to manage that airway. And I can't emphasize enough how escalation and having a backup team in that situation is very important, especially for tertiary level 3 neonatal centers. Now, what is very interesting is we talk about having frameworks for escalation, frameworks where we have colleagues from the ear, nose, and throat department and pediatric anesthetists to help us. But what we realize is it's not as simple as that. So if I just give you an idea, we have a total of 220 neonatal units in Ireland, England, Scotland, and Wales. Now, 63 of those units, which are the units in blue, as you can see in this diagram over here, are tertiary neonatal units. And I would like to think that our tertiary neonatal units have got access to a pediatric anesthetist and pediatric ENT. That leaves the remaining 160 units in the rest of the country with need, if they run into problems with the airway, of having to rely on their local help. That would not be a pediatric ENT or a pediatric anesthetic specialist. That might just be an anesthetist, an adult ENT specialist. And for a DGH pediatrician, it might even just be a colleague. You might not even have access to these facilities. So I can't emphasize enough how, when you look at the frameworks for management of the difficult airway and a multidisciplinary approach, we are in a very difficult situation in the UK. I think the important thing from our perspective is trying to look at our setups and trying to engineer approaches, which means we can get these people to our facilities in good time if we find that we have a baby who's got difficulties with management. So how do I describe management in the UK? So in 2014, Fawzia Pays from Liverpool Women's Hospital actually did a survey of all the 63 tertiary neonatal centers in the UK. And what was very interesting was that only 67, that's 2/3 of these centers, actually had a difficult airway kit. Less than 2/3 actually used end-tidal carbon dioxide or capnography to actually detect that the endotracheal tube was in the right place. And none of them actually looked at limiting the number of attempts. So the 2/3 of units who didn't use capnography did not have any guidelines for limiting number of attempts. So very interestingly, if you looked at the difficult airway kit for the remaining 67% of the units, they had different devices which were organized in different ways. So at that time, our unit basically did not even have a video laryngoscope. We only started using a video laryngoscope in 2015. But the airway kit had oropharyngeal airways, LMAs, boogies. So different devices, the training of which is absolutely imperative. Now, my trainees are not even... my trainees are not used to actually using a video laryngoscope, and we have to train them in its use. So what this demonstrates to us is that there is a huge variation in how units just in the UK were managing the difficult airway at that particular point of time. If I were to emphasize, only one unit of the 63 had a can't intubate, can't ventilate policy for neonates. Now, if I compare that to the pediatric population and pediatric intensive care units in the United Kingdom, the DAS guidelines, Difficult Airway Society guidelines, are a validated set of guidelines which basically take you through a pathway of failed intubation, can't intubate, can ventilate, and can't intubate, can't ventilate situations. And what they have done is been able to standardize their difficult airway management kit so that you can go through that algorithm in a structured way. And having that means cognitively teams are prepared and trained to be able to manage these three situations to the most effective of their abilities, and that actually produces better outcomes, is the evidence. In 2015, it became imperative for us to start thinking on those lines. And I'm part of the Advanced Resuscitation of the Newborn Infant Working Group, who basically has set up the ARNI course in the United Kingdom, which is currently run in a number of centers. And they were the first, I would say, neonatal group to come up with guidelines for management of the difficult neonatal airway, specifically focusing on situations which included the can't intubate, can ventilate scenario in a neonate, and the can't intubate, can't ventilate scenario in a neonate. The main emphasis from their perspective is you need to have a backup difficult airway trolley or equipment keeping area where you can standardize the equipment so that everybody using that is trained in its use, but is also trained in the use of the airway adjuncts that you use in your local setup. With that in mind, I think there was a clear recognition that the ARNI group on its own running 5 courses in a year would not be able to produce a national standard for such a variety of centers, that's tertiary centers, as well as neonatal intensive care units, as well as special care baby units. So in 2020, I was part of a working group which developed the management of the difficult airway in the neonate framework for practice, which again emphasized on having a structured approach to keeping equipment and a structured approach to clinical assessment and management if you have difficulties with mask ventilation or with intubation of babies. Now, how common is this? So to give you an idea in our setup, we have about 6,000 live births in our level 3 center. We have 6 to 7 cases of difficult airway management every year on our neonatal unit. And the most common reason for that is it's usually a failed intubation attempt by a trainee prompting escalation to a consultant, which then necessitates intubation by the consultant. However, not unexpectedly, we're a quaternary unit. We manage difficult airways, and we have a variety of babies who come to us with a lot of, I would say, structural airway problems. So over the years, we've managed babies, preterm babies with Beckwith-Wiedemann syndrome, preterm babies with severe subglottic stenosis, babies who are severely hydropic, who have significant cystic hydromas. Interestingly, we've had the odd baby with trisomy who's had severe tracheomalacia and been difficult to intubate. And then we manage babies with Pierre-Robin syndrome. On an average, what I would say is of the 6 to 7 cases of difficult airway management every year, we usually have 1 or 2 cases who have structural problems. And where possible, we manage these babies antenatally with a team that manages these babies using an exit procedure, which involves an experienced ear, nose, and throat consultant, as well as a pediatric anesthetic colleague. And we usually plan well in advance for delivery of these babies. Our management is complicated hugely by the fact that we don't have ENT or pediatric anesthetics on site in our hospital. Our hospital is separate to the main hospital, and a lot of the equipment that they have to use has actually to be bought by them, including the fiber optic scope. So what we've done is develop some standardized guidelines to manage the difficult neonatal airway. And what I'm going to talk to you about is management of the unanticipated neonatal difficult airway. So first of all, we need to differentiate both of these things. And what I would say is that if you have a baby who, say, has a cystic hygroma, or you have a mother who has severe polyhydramnios in the setting of a baby who's scanned to have a very small chin, which is less than 5th centile for that baby's gestational age, then those are cases like a Pierre-Robin, where you have the potential to plan ahead and risk assess. Now, experience says those are babies where we would try to deliver those babies, hopefully within hours, where we choose the time, place of delivery. We manage the number of personnel and the teams. From a neonatal side, it would be a 4-member team with standardized personnel, 2 people to manage the airway, breathing, a person to manage circulation access, and a very experienced nurse who would help with monitoring and equipment. We'd have had discussion with the parents about management, and our equipment would be prepared. The problem is if this Pierre-Robin comes in at 3 o'clock in the morning and we're not prepared, and the important thing is we need to have an escalation strategy because you want to give the baby the same outcome. And that escalation strategy in our setup is developed in such a way that we have clear pathways for calling ENT and anesthetics out of ours. So a direct phone number to the ENT team, a bleep for the pediatric anesthetic registrar. They bring their equipment and we have our own difficult airway trolley. That means that this baby, if it delivers at any time 24/7, would have a strategy for management if it delivered unexpectedly. Now, how do we manage the unanticipated difficult neonatal airway? So what I'm going to talk to you about is two approaches. So the first approach is a human factors approach. Now, the human factors approach basically means that we first recognize a difficult neonatal airway. So for our trainees, any trainee managing an airway who has difficulty mask ventilating and inflating the chest, or has or fails their first intubation, that's an experienced trainee having a single attempt of laryngoscopy where they either can't visualize the glottis or they can visualize the glottis but can't pass the tube. So that is the situation. Would put out an escalation crash call, which is a 222 crash call, which gets a 4-member team there, which includes a consultant within hours from 8:30 to 11:30 in the evening. After 11:30, the consultant's at home, and it's well known that in that situation, the nurse coordinator will call the consultant in from home. But at that delivery, once you've failed to mask ventilate the baby or passed an endotracheal tube for the first time, a crash call will go out to escalate to get that team to the baby. The teams are trained in such a way that the first responder, who might be the junior most member of the team or the SHO or the registrar, will communicate in SBAR to give us a good idea of what the problem is. And if this is difficulty in mask ventilation or difficulty in intubation, after having done MR SOPA, what we would normally try to establish is where and why and what was difficult about that intubation, so that we can share a mental model of deciding why this airway is difficult. That then means we can change how we manage the airway. It often means that the most experienced person responsible for the baby at that particular point of time, who can manage the airway or intubate, takes over the airway. We have a person who then takes a step back and becomes the person with overview or global oversight, who's called the lollipop person, a dedicated nurse who helps with equipment, and usually have a runner available in case we need additional equipment, with a consultant either there or on the way. Key things that we train, so we simulate a lot, and Justin, my colleague, is going to talk to you about that, is in situations like that, if you're having difficulty with either intubation or mask ventilation, is not to panic. Now, how do you not panic? So one of the things that we've learned over the years is a concept that we call stress inoculation. So I run simulations, can't intubate, can't ventilate scenarios, where we've got specialized mannequins, which babies are modified with their airways, which Justin will probably talk to you about, which basically are difficult to intubate. But what we do is we put trainees in those circumstances along with our nursing colleagues, and we let them perform with the specific training that they get used to managing those situations where babies are specifically bradycardic and deteriorating. Now, if you're able to manage those situations in simulation, the expectation is that you should be able to duplicate similar management in real life. But if you do those simulations again and again and again, what happens is you ameliorate your own stress when the real situation presents. And that concept is called stress inoculation. And it is a very, very good technique for training people in difficult airway management. I think a key area for emphasis when we train is to call for help early. So clear objective definitions of when to call for help. So no movement of the chest with mask ventilation in a baby who's bradycardic needs a crash call. The inability to intubate on the first attempt, whether that's due to human factors or whether that's due to a structural problem, needs a crash call. Mask ventilation of that baby and 100% oxygen is key. But other things are very important. Well, once the team arrives, who is team leader? Who's taking the step back? Who's doing airway breathing? Who's managing circulation and equipment? And the most important thing is there's a lot of noise in that environment. Now, how do you minimize and share mental models when people are talking over each other? And that's why it's so crucial to establish a team leader who can actually manage the noise in that environment, manage communication so that it's effective and it's closed loop. The most important thing is whenever you have difficulty in situations like that, you need to make sure that you can at least mask ventilate the baby. You can move the chest. And I can't emphasize enough, in small babies and in preterm babies, it's very easy to inflate the stomach if you continue IPPV for a long period of time. Now, if you inflate the stomach, you splint the diaphragm, and you can convert a baby who's ventilating quite easily into a situation where you can't mask ventilate because the diaphragms are completely splintered by an inflated stomach. So what you need to do is use a nasogastric tube. Preterm babies have very large tongues. They tend to develop glossoptosis. Now, the use of a Goodell is advised in situations like that, but be aware that even with a Gadel, there's at least one study which now demonstrates that it can make glossoptosis worse. So if you can't get a Gadel in and mask ventilate, you need to go back to what was working. The most important thing is for anybody having another attempt at intubation, that should be a fresh attempt, changing your approach, and it's thinking about what you're going to change about that. Now, that is a human factors approach. What about the clinical approach? And I'm going to keep this really simple. So if you're in a situation where you're having difficulty with intubation, there are two problems that you will face. You will either be able to not see the glottis. Now, a classical example is an anterior larynx in a baby with Baer or bend. So the airway is very anterior. Because the airway is anterior, you can't see the glottis. What you can do is you can mask ventilate that baby. And the important thing in that situation is that you don't keep having blind attempts at intubation. The other situation that I've recently come across is a baby with very severe microstomia. So this was a baby who had what we call a collodion baby, and it was impossible to open the mouth of the baby, and this baby had significant respiratory distress. Now, we did not need to intubate that baby. All we used was humidified high flow at 7 liters in 100%, and we allowed the baby to adapt from birth. But the most important thing was making a plan for secondary intubation. I'll come to that later on. Babies with Beckwith-Wiedemann have very large tongues, and sometimes using straight Miller blades, which are narrow, do not allow you to actually effectively visualize the glottis. And we'll see some videos of this when I speak about this later. But use of broad blades, and we keep one size of broad blade, which is a Seward blade on our Resusstair, and I can't emphasize enough how that has bailed me out in babies with trisomy 21 and babies with Beckwith-Wiedemann, because it allows you to sweep the tongue out of the way to give you a much better view. But the key point I'm trying to emphasize here is you either will have difficulties with visualizing the glottis or a partial view. But the other situation is you can see the glottis, but you can't intubate the baby because there is either a structural problem or you can't advance the tube, maybe because you're using a tube that's too large. Now, you can manage both these situations, and I would always emphasize to you to avoid repeated failed attempts for intubation. But before I go through the clinical approach, what I'd like to say to you is, have you called for help? Or if your trainee is in this situation, have they called for help? And I would like you to think about whether you have an escalation strategy of how they call more experienced people, pediatric ENT or anesthetics in situations like this. I think the most important aspect of management of babies like this, if you're going to have another attempt at intubation, is trying to optimize your view. And a very simple thing that helps in situations like that is the grading, the Malampati grading, which basically talks about the grade of intubation. So if I had a failed attempt at intubation, but I had a grade 1 view, this might be simple. It might be secretions. And actually, the use of suction to clear secretions might be the only thing that I need to do. On the other hand, if this is a baby with Pierre Robin, where I have a grade 3 view, cricoid pressure might not help. And in this situation, actually, this baby might need to have a fiber optic intubation because we can't get the tube in. But what might help in this situation might actually be the use of a boogie. Similarly, the use of a radiolaryngoscope. And what we've trained and what we emphasize to our trainees when they have their first attempt at intubation is trying to have some idea of what grade of intubation this is. Were they able to clearly visualize the glottis vocal cords? Was it clear? What was it the reason that they failed? Was it secretions? Was it the tube not being curved anteriorly? Or alternatively, was this a grade 3 view and this baby has a very, very small chin? And once you look at it in Sapir or Ben, you automatically know that the most experienced person should be the next person either managing the airway or intubating this baby. But actually, if my trainee could not manage to intubate this baby and found this view, what he could use is use a laryngeal mask airway or an IGL in this situation to ventilate the baby, which is less traumatic and which will allow effective ventilation. So it's a very good method of getting trainees to think about the grade, the visualization of the glottis. Now, one of the questions that we commonly ask people, and I've asked that in a poll that I've sent out to you prior to this presentation, is actually how many attempts at intubation you would have if you were having difficulties ventilating. And what I would say is that the basics remain exactly the same, but I'm very keen to know from you how many attempts you'd have in terms of intubation. So would you have 1, 2, 3, or 4 attempts before you called a senior for help? So let's see what the audience poll actually comes up with. I think the key thing is if you're having another attempt at intubation, at least in our setup, we would almost certainly be calling a consultant or a very experienced person as backup. We would be mask ventilating this baby in 100% oxygen, and we would aim to optimize things. Now, what we also have is the ability to be able to use specialized adjuncts in our setup. And I always ask my trainees in situations where they fail intubation is to think about what else they might be able to use in situations like that. And it might be that actually they can mask ventilate this baby very effectively. So put a nasogastric tube down, get a chair, sit down, relax, get somebody to make you a coffee, move that chest, make sure that you can saturate this baby, that its heart rate is coming up, get a nasogastric tube down, get somebody decompressing, because you can continue doing IPPV while help arrives. I think the most important other aspect to it is if you're in a situation where you can't see or you're struggling, you can use an iGel or an LMA. And we've got some very nice videos on how to use an iGel or an LMA in situations like this. What these devices will enable is for you to temporarily manage the airway and provide IPPV in a very effective manner. In our setup, the other thing that we've used, which is very helpful, is video laryngoscopy. And we'll talk about that when I talk about the next task-oriented management in the can't intubate, can't ventilate scenario. For structural airway abnormalities, you need to call for help. And what I'd say is if you can see the glottis but can't pass a tube down, the question from your perspective is, do you need to suction? Is the trachea obstructed? Do you need to downsize your endotracheal tube, use one size smaller? Can you use a boogie to intubate on top of a boogie if it's a very snug fit? If you can't, then avoid failed attempts at intubation. And I would say that the important thing is to continue mask ventilation in 100%. And you should consider escalating to an experienced neonatologist, ENT or pediatric anesthetist. In our setup, they would help with a fiber optic intubation in situations like this. We would commonly in those situations try to use an LMA or an iGel or continue mask ventilation if we had any problems. So just to give you a little bit of an idea, when you're in that situation, how does ENT and how does a pediatric anesthetist help you? So in our setup, they can provide fiber optic intubations with a special device, which is called the Lindholm or the Bonfil device. They can use a 2.2 fiber optic scope. So they can bring that and help with the intubation. But very rarely, you might get a baby who's got a structural airway abnormality like subglottic stenosis, or you might have a problem where a baby has got what is tracheal stenosis. Now, those are situations where even a fiber optic intubation might not help. And the only thing that will save a baby in situations like that is a surgical airway. So our escalation strategy in our hospital is we default to ENT because they can do both. They can help us with the fiber optic intubation. They can do a tracheostomy. Can I emphasize to you that a cricothyrotomy is not recommended in those circumstances? So the airway in a term baby, it's millimeters. The cricothyroid membrane and the airway getting through that, it's literally millimeters to get through that. Experience says that for people who try to do a cricothyrotomy in situations like that, you end up wrecking the trachea. And that means that if somebody is coming to help you get a surgical airway, they find it even more difficult. In my career and 20 years of doing this, I've never ever had to do it, nor have I ever escalated for it. Now, just one aspect. You have to differentiate between the baby who you can ventilate and can't intubate versus the baby who you can't intubate and can't ventilate. And I can't emphasize this enough. So if you're trying to intubate this baby but having difficulty, you can see the glottis is wide open. Now, if you could not pass a tube, but you passed an LMA in this situation, you'd be able to inflate the chest quite easily. Over here also, if you used an LMA or an iGel, you'd be able to inflate the chest and move the chest. But this is a baby who's got glottic hypoplasia and tracheal stenosis, and this is tracheal atresia. Now, can you imagine using an iGel or an LMA in these situations? They won't work. So what I'd say is that if you're using an airway adjunct like an LMA or an iGel, but you cannot produce effective chest wall movement, but were able to do that with mask ventilation, please go back to using mask ventilation as your default. Put a nasogastric tube in, decompress, and you should have help on the way. I think just to give you a little bit of an idea, so this is a normal airway. over here that you can see, which is open with the glottis, so an endotracheal tube can pass across. And what you can see here is you've developed complete tracheal stenosis over here with a membrane. So actually, you would not be able to intubate this baby, nor would you be able to actually manage this baby with an LMA or an IGEL. And this is usually a situation which is fatal in babies. It's can't ventilate, can't intubate. But in babies who, say, for example, have a patent airway, if you have repeated failed attempts at intubation with a large tube, what will happen is these babies will develop glottic edema. So you can easily transform a can intubate, a can't intubate, can ventilate scenario into a can't ventilate, can't intubate scenario just because of failed intubation attempts. So I would always say that if you are unable to intubate in your first attempt, go and default back to what was working and moving that chest. Think about why you failed, what you're going to change about your next attempt. But having more than 2 attempts by the same person risks repeated unsuccessful attempts, which actually puts the baby at risk of glottic edema. And then even very experienced people will not be able to manage that baby. So how have we standardized our pathway? So I'm coming to the end of my talk. So I've given you a human factors approach and I've given you a clinical approach. So in our setup, what we have done is we have got a standardized approach, which talks about the first failed intubation, who to call for help when you fail your first intubation. And assuming a trainee is doing their first failed intubation, they're unsuccessful in that attempt, they would put a crash call out during the day or call us via switchboard overnight, continue ventilating the baby. And then what we provide is a traffic light system which says, these are the problems you might face. So you can have a nurse reading this out to you. But we've developed a trolley, which basically is color coded. So it has all the equipment to optimize ventilation in this situation. So if I have a baby with severe micrognathia, I can use an oral or a nasopharyngeal airway, and that is kept in the green part of the trolley. On the other hand, if I've got a baby with severe Pierre Robin, and I want to use a Goodell or I want to use a boogie because I've got a partial view, then that's actually kept in C draw. And if I want to use the video laryngoscope, then everything for a fiber optic intubation and video laryngoscopy is also kept in C draw. On the other hand, if I have a situation where I've got a structural airway abnormality, tracheal stenosis, and I can bag this baby, but I can't get a tube down, then I should avoid further attempts at intubation. And we have a standard escalation policy which says, call this number, call ENT, bleep them, tell them to activate the Making Airways Safe trolley pathway. They will bring their equipment, and everything for a tracheostomy and a fiber optic intubation by them, including blades for the anesthetists, are actually kept in the red part of the trolley. So actually, using this simple algorithm, you can see how from your perspective, you can actually get and do things in a team in a very rapid way. How do we use this particular trolley? So it's kept in our intensive care room. It can be rolled out. We've also got a grab bag, which has all the equipment, which is color coded exactly like this. So if you have a problem on labor ward or upstairs on the postnatal ward, we can actually use it in that setup. The key thing from our perspective is, how do you use this in the actual clinical scenario? So I'm going to give you a small example. So midnight in my hospital, 6 months back, we had a baby being born, giving birth to a term baby who had severe polyhydramnios. Now, the polyhydramnios was so severe that she ruptured membranes and she was extremely uncomfortable. So actually, our obstetric team informed us that the baby has very severe polyhydramnios. The antenatal scans showed a large anterior neck mass, massive. And they had planned at that time to take this mother for a category lower segment cesarean section. So the actions that were taken by my registrar were immediately, this is a situation of a difficult airway. So he called me, he escalated to me even before the baby had delivered. And I said, please do not take the section forwards until I've got on site. So we postponed the cesarean section and we made an airway plan where we decided from our perspective that if you've got such a large neck mass, it would be unsafe to deliver this baby without the support of the NT on site. So actually we decided to postpone the delivery to the daytime hours, speak to the ENT team in the morning and organize for the delivery to take place via elective cesarean, just because it was for maternal discomfort. There was no risk to the mother, no risk to the baby. So we ended up doing this section the next morning with the entire team there in preparation for an exit. Now, this is what the baby looked like. And I kid you not, if this baby delivers and has acute airway obstruction in the morning at 12:15 and we're not prepared, we'd be in a situation where we would not have been able to manage this baby. Now, our intubation pathway for this baby was actually, do we need to intubate? Because if the baby comes out crying and has a stable airway, what we want to do is oxygenate, put this baby on high flow and let the baby adapt. But if we needed to intubate this baby, it's clear that would not be easy. So A, we decided to take a broad blade with us. But more importantly, what we agreed is that because of the hyperextension, if this baby needed a formal airway, we would have to aspirate the cystic hygroma, and that would be done by my ENT colleague. What we would also do from our perspective is have only a single attempt at intubation with a broad blade. And if we failed, the next step would be fiber optic intubation by my ENT colleague in that particular situation. I think you can understand that doing a surgical tracheostomy in this baby would be fraught with disaster. So I'm going to summarize by saying that from our perspective, what you need to be able to do to manage the difficult neonatal airway in your setup is have an algorithm which looks at a standardized approach, which is valid for your setup. Now, not everybody will have video laryngoscopy. I'll be covering that in the talk after this. But having an iGel, having a broad blade, having a nasopharyngeal airway, all of these things can bail you out. And the most important thing is you need to be trained in them. So if you look at our pathway that I've got over here, the pathway basically provides options for trainees and clinicians in pediatrics and neonatology to manage the various situations without intubation. So for micrograthia, you can use an oral or a nasopharyngeal airway. You can put the baby on high flow. Similarly for microstomia. For a baby with macroglossia, you can use a broad blade. If you have a large term baby who's very vigorous, does the baby actually need to have intubation drugs? It might be that you can wait, manage the baby with IPPV, get some access, give this baby intubation drugs. If it's more difficult, what about the use of gas, getting your anesthetic colleague? Because actually with gas, you can keep the baby breathing, you don't take the baby's drive away. But if the baby has a partial airway problem where you can't visualize the airway or you can partially see the airway, then in that situation, you can use an LMA or an iGel if you don't have a video laryngoscope. If you have a video laryngoscope and you need to establish the airway, then you can use that. And we'll talk about that in the next talk. But most importantly, if you have a structural airway problem, then really what you need to be thinking of is having an ENT colleague there. And these are babies where I would try to plan in advance if I know. If I don't know, then I'm going to emphasize the mortality of these babies in delivery suite, even in our setup, is very, very high. So you can only do what you can do. But by having this algorithm and having standardized equipment kept in a structured way, you eliminate a lot of the problems with equipment, human factors, communication. So you can imagine looking for an iGel at 3 o'clock in the morning. Where do you keep it? How do you find one? Our policy is standardized. Our equipment is kept in one place. As soon as we have a first failed intubation, we go into escalation mode, and then we go into equipment mode. If you can think of your situation and how you would develop that in your situation, it's worth looking at how you would train for this, how you would develop a pathway for this. And for everybody who's working in a tertiary or a quaternary setup, I think in the neonatal setting, I think everybody should have a pathway which thinks of, if you had a critical airway, how you would get somebody to be able to give you a fiber optic intubation or a tracheostomy where possible. Thank you. That finishes my talk.
Thank you, Alok, for an excellent talk. Can I ask you what happened with that baby's airway? I know we will have a discussion in the end, but
yeah. So what we didn't have to do anything. So the baby came out and was breathing without any problems. So as you can see, we put a nasogastric tube down. The baby started some high flow and adapted. But in order to take this baby for surgery, we had to develop a pathway for management of this baby. So this baby was intubatable with a broad blade, and it was intubated by my pediatric anesthetic colleague using a broad suet blade. I will be showing that to you in the next talk. Failing that, I think the plan, as we discussed, was to aspirate the cystic hygroma and then for ENT to do a fiber optic intubation. But he was actually intubatable with a broad blade.
Very well managed and good plan. Thank you. I think we'll have the discussion at the end. Thank you so much for, you can stop sharing the screen now. And Rajesh, are you there?